the last part of the lecture, which has a little bit of clinical application. So this is an orthopantomogram or panoramic X-ray, and this is one of the most used X-rays that we will see. Well, in this X-ray, there's nothing that looks abnormal. What we can see here, I know that there is a lot of interposition of structures, and that is common in this type of X-ray, but we can discriminate where are the condyles, where is the coronoid process, the angle of the mandible. We can see as well like the whole upper arcade and the lower one, so it will show us like the biggest picture of the patient, and also we can see the relation with the inferior alveolar nerve there, or well, in this case we can see the mandibular canal here. As also we can see the maxillary sinuses here. So this is the close relation of the maxillary sinus with one of the cases when we ask for this X-ray, for example, is when we want to assess the position or also the presence or absence of the third molars, when we suspect, and also the relation with this canal, if there's any, for example, like increase of volume that we consider abnormal, and we want to see. So this will give us like a general scenario of the patient. So in this case, the radiologist says that, or report that this is a normal OPG with absent wisdom teeth in all the quadrants, and there is nothing abnormal apart from the absence of the third molars, so nothing else has been reported here. When you find something abnormal, now in this one, the report says the mesio impacted lower third molar, the 3/8 and the 4/8, with the root of 3/8 here, seen in proximity to the mandibular canal, as we can see. Partially erupted left upper third molar. So the 2/8 is partially erupted here. And in this one, now, why did I show the previous one? Because we could see like the normal OPGs, and in this one we can see that the person required this X-ray reported from the clinical history that the patient referred right upper dental pain and also fever, and the report from the radiologist says extensive dental caries of 1/6, and we can see here 1/6 with this radiolucency here. So this is the caries that is having this patient, and with a marked lucency surrounding the roots. So this is the radiolucency here. Particular, so in keeping with the odontogenic infection, and then he also refers that 2-6 is absent, and also 4-6 is absent here. Well, restorations are present in all the quadrants, including 1-6. So this is a good example of a dental caries that is spreading into the roots, and that will cause a periapical infection, but also see the location of the maxillary sinus here, and we can see how close the roots are, and therefore if there is any infection here, this can be spread into the maxillary sinus. So this is a CT scan, and the dentist reported that the patient said in the clinic he had fever, sore throat, toothache, and also nasal discharge of a week of duration. And after looking at this clinical history and taking the CT scan, the radiologist referred that he wrote that there is an periapical abscess of the upper first left molar with associated complete obliteration of the left maxillary sinus with high density fluid that shows 2 air bubbles inside and obliterating the left osteomeatal complex. So this, so there is a sinusitis of this left ethmoidal. Right now in the CT scan, we can see, so now this is a CT scan, and the dentist reported that the patient presented with fever, sore throat, toothache, and nasal discharge of 1 week of duration. So this came to the radiologist, and the radiologist took this CT, and he reported there is a presence of a periapical abscess here of the upper first left molar tooth with associated complete obliteration of the left maxillary sinus with high density fluid here, showing 2 air bubbles inside and obliterating the left osteomeatal complex. And this sinusitis is also associated with the left ethmoidal air sinus here. So in this case, he reported that the diagnosis is an acute left maxillary sinusitis secondary to periapical abscess of the first left upper molar tooth. Here we have from the same patient a coronal section, but this section has been taken a little bit more posterior than the previous one, and is still of the 2-6 tooth, and the report also says that the left maxillary sinus is filled with fluid with these 2 air bubbles And in the case discussion, the tooth caries that we can see here and the periapical abscess may lead to maxillary sinusitis through direct extension of this infection through the maxillary alveoli. Well, and in this case, the case or the presence of the bubbles and also the level, in this case, of fluid or air will suggest an acute episode. So this is a perfect example that show us how infections can invade other places, and we need to know the anatomy so we can understand the areas that can be involved. So now I will show you So in this X-ray, we can see here that one of the roots of the first upper right molar has been displaced into the maxillary sinus, probably during an extraction. Right, so I decided to put that video because I think it shows very well what is the treatment after the displacement of the root into the maxillary sinus that can be produced after a iatrogenic treatment. So, for example, if we keep pushing and pushing one of the roots when we're doing an extraction, rather than helping the patient by taking that root, if we don't remember that the first upper molar tooth is located near to the maxillary sinus, then we can actually communicate the oral cavity with the maxillary sinus, and not just that, we can push this root into the maxillary sinus. So the patient will have to go through this more invasive or treatment that wasn't needed at the beginning, and that probably wouldn't have been needed if we knew the anatomy of this area. Right, so now that we know the anatomy of the nasal cavity and also the paranasal sinuses, I would like to give you a different approach about the relations of these structures with what or with the clinical practice. We will have a look of different investigations related to different areas, but all related to the anatomy that we have just covered. So the first one is how I do it, endoscopic endonasal approach for pituitary tumor. So to access the anterior skull base, there is an endoscopic endonasal surgery, and this has been evolving, and we can get into a more or will provide us now a minimal invasive alternative when compared to open techniques. So this investigation presents us a basic access to a midline lesion, and this is a fundamental starting point for wider access to the skull base. So the imaging techniques that are needed are MRI and CT scans. So these will be performed pre-operatively, and they are mandatory to examine the size of the tumor in this case. Also the paranasal sinuses are assessed to see if there is any variation, the sphenoid sinus, and to see if there's any nasal deformity, for example. Well, the technique will consist in the insertion of a 0 degree, and the right middle turbinate is removed, and the pituitary tumor can be reached through the right nostril in this case. The left middle turbinate is lateralized by pressure with an instrument known as elevator, and then there is a nasoseptal flap harvested on the right with this vascular pedicle, containing the nasoseptal artery, which is a branch of the nasopalatine artery. And we have to remember that we are near to the olfactory epithelium, so we need to stay below this olfactory epithelium. The landmarks in this procedure are shown in this image. So we can see that here we are in the sphenoidal sinus, but from an anterior view, and it has been an opening of the front wall of the sphenoidal sinus, and this will allow direct access to the anterior wall of the sella turcica. This is what we can see here. And laterally, we can see where the carotid arteries will be running through the cavernous sinus, and superiorly the optic nerve. Optic chiasm is where this will meet. Now, in this image, we have a view, but when the procedure has nearly finished. So we can see the cavity after the tumor has been resected, and this is the material they used in this technique. So it's flowseal, and the indications for this technique is approaching the anterior part of the skull base when there are lesions based in the sella turcica and suprasellar regions. Also for pituitary adenomas, microadenomas, and also macroadenomas. The limitations are when there are lesions, such, for example, craniopharyngioma and pituitary adenoma that extend like over the carotid artery laterally. So there won't be access here or enough access or accessible access here. So we'll require a combined technique. Right, the complications that there are need to be avoided, for example, is the CSF leak. And the best way to avoid this is by using this nasoseptal flag. The considerations that need to be taken are not to damage the residual pituitary tissue, so this will preserve the pituitary function. The carotid artery is only exposed if discussed pre-operatively during the assessment of the CT. And in the conclusion of the investigation, they reported that this technique has provide a safe procedure that has a low incidence of complications and also has an excellent potential. Here we have another study, the Incisive canal, and this is a comprehensive review. Right, so in this case, the incisive canal or nasopalatine canal, or also known as anterior palatine canal, is an interosseous conduit through the anterior part of the maxilla that will connect the nasal cavity here with the oral cavity, and there are neurovascular structures that will be passing through this canal, including the nasopalatine nerve that provides sensory input from the pterygopalatine ganglion from the mucosa of the hard palate, the gums that are around the incisors, and we will go until the canine. There is also an anastomosis between the posterior septal branch of the nasopalatine artery and the greater palatine artery. And this canal will end at the incisive fossa in the oral cavity, located posterior to the superior or the upper incisor, beneath the incisive papilla. And superiorly, this will extend to the nasal cavity on each side of the nasal septum as the nasal foramina. It has a characteristic V shape or Y shape, and on average, it has a length of 10 millimeters and the width up to 6 millimeters at the incisive fossa. The dimensions of this canal will increase with the loss of the dentition, and also can increase with the age, if there is any cyst formation, or if there has been any trauma. Clinical aspects, if there is an option of a dental implant, as the maxilla is more trabecular when we compare it to the mandible, it has more chances of a progressive reabsorption of the bone, and if this happens, then there is a potential osseointegration failure of the dental implant. And what is running here? The nasopalatine nerve, the nasopalatine artery, or also known as spinopalatine artery, and they can be damaged during restorative dental procedures. So there is a risk of sensory loss to the anterior palate due to damage of the nasopalatine nerve. Of the dental implant in the anterior part of the maxilla is highly dependent on the anatomy of the incisive canal. Now, epistaxis or nasal hemorrhage is very frequent, approximately 60% of prevalence in general population, being 80% of the total nosebleeds anterior. And they will involve this Kesselbach's area. This bleeding generally will be managed with a more conservative approach, but if it doesn't stop, for example, it will need a surgical intervention by cauterization, ligation, or embolization. And surgical interventions usually will access the posterior septal branches of the sphenopalatine artery or the maxillary artery. An endonasal cauterization of the sphenopalatine artery can happen or can be accessed entering through the incisive canal. This has demonstrated an alternative to stop this anterior epistaxis. Now, when we consider a nerve block of the nasopalatine nerve, as this one provides sensory innervation to the nasal septum and also the anterior mucosa of the hard palate and also the palatal gingiva of the anterior upper 6 teeth, where it overlaps with branches of the greater palatine nerve. So these maxillary incisors are mainly innervated by the anterior superior alveolar branches of the maxillary nerve, and the nerve block of the anterior superior alveolar branch sometimes won't be successful, and this can be due to variations in the nasopalatine terminal branches that will be innervating the maxillary central incisors. So, the CT scans are the best medical imaging modality to assess this incisive canal, as it gives a better resolution. It also eliminates any superimposition, offer less radiation to the patient, and will provide better analysis for the quality of the bone. In this image, we can see a sagittal section of the incisive canal. So this is anterior, this is posterior, this is superior, inferior, and the white arrows are showing us the incisive canal, and also here in marked by A and S, this is the anterior nasal spine. Now, we will continue with what we have seen before. So the odontogenic sinusitis, a case series studying diagnosis and management. So this is a type of sinusitis that even it is well recognized, it has not been very well studied. It requires a unique diagnostic criteria, and also the treatment is different from a sinusitis of a non-odontogenic origin. This is an inflammation of the sinuses. Remember that everything that finishes in itis or itis means inflammation, but in this case, the sinusitis will have dental origin. And historically, it has been proved that the cause can reach up to 10 to 12% of the sinusitis cases, but new studies have shown that this number can increase up to 41% of the cases. Hence, this cannot be ignored by us as dentists. Dental pathologies that can produce this include infections arising from maxillary teeth, maxillary dental trauma, and also dental procedures. Even that this subtype of sinusitis is recognized, the odontogenic sinusitis is difficult to differentiate clinically from other types of sinusitis, as it has not a specific presentation. What happens is that the poor recognition of this odontogenic sinusitis will provide an inadequate treatment of the patient, and this can lead to a prolonged disease, and obviously, so it is very important that we diagnose this very soon, and also give the patient the treatment needed, as this treatment will differ from non-odontogenic sinusitis. So from a total of 55, so from a total of 55 patients assessed in this study, the CT images showed that 84% of the patients had unilateral odontogenic sinusitis, and 16% of the patient had bilateral odontogenic sinusitis. 45% of the dental pathologies consist of a periapical disease, including cyst and abscess. 28% consist of oroantral fistulas, and 14% were due to foreign bodies, including implants or grafts, and the other 13% was due to congenital abnormalities. So, for example, tooth roots within the maxillary sinus. So, misdiagnosis in the clinical practice can be even higher, and this is why it's so relevant to differentiate between the odontogenic sinusitis from the other type of sinusitis. However, there are no symptoms that are clinically unique to the odontogenic sinusitis. Even the cause can be dental. Studies have shown that dental pain is not a specific symptom, and the absence of this symptom can be related to the lack of pressure in the site of infection, as the maxillary sinus permits the drainage and also the pressure relief. And there is a recent study that showed that when compared to CT, dental radiographs missed approximately 60% of apical periodontitis, as well as 90% of apical infections that can extend into the maxillary sinus. Management options for odontogenic sinusitis are very similar to the non-odontogenic ones, with the addition of the dental surgery, and there's also a complementation of medical management and endoscopic sinus surgery. So dental procedures that can be performed and lead to the end or remission include the extraction of the tooth and oroantral fistula closure. However, specific management protocols for odontogenic sinusitis are still not established. When you suspect of odontogenic sinusitis, the first step is to perform like a complete dental history and also oral physical exam, and patients who had dental symptoms may recall a temporal relationship between sinusitis symptoms and also dental procedures, or if evaluating the patient would have, for example, a tooth or a tooth that is in poor reparation, we can consider that there is a possible odontogenic source. So there is a need to assess with a CT scan to visualize the maxillary teeth, and if this reveals any sinusitis in relation to the maxillary sinus. Then the clinical assessment must be performed to recognize which is the dental source. And this study suggests that dental surgery is the first line in surgical treatment for odontogenic sinusitis, because it is logical to target the cause of. Right, so this is the last study, simultaneous oroantral fistula closure and sinus fluoramentation to facilitate dental implant placement or orthodontics. So, in this study, OAC means oroantral communication, and this has been defined as a space created between the maxillary sinus and the nasal cavity that, if is not treated, it will progress into an oroantral fistula or a chronic sinus disease. The most frequent cause of the oroantral communication is maxillary molars or premolar extraction, and this is due to the proximity of the roots to the sinus floor. approximately 90% of these patients will progress into sinusitis if the communication is not treated for 2 weeks or more. So the oroantral communication with less than 2 millimeters of size will usually close on its own, but when they are larger than 3 millimeters, they can progress into an oroantral fistula in the absence of treatment. And the range of frequency of this complication has been described from 0.31% to almost 5% of the cases. And there are different techniques to treat these communications. Right, so I have also included in my research the following investigations, treatment options for odontogenic maxillary sinusitis, long-term effectiveness of maxillary sinus fluoromentation. This is a systematic review and meta-analysis, and also a novel reconstructive technique after endoscopic expanded endonasal approaches, vascular pedicle, nasoseptal flap. So, in summary, we have covered the anatomy of the nose and the paranasal sinuses, the oral cavity and the pharynx, and also a little bit about the larynx. And we have applied this anatomy to clinical cases. So thank you very much for watching this lecture. And here I'm leaving the references I have used and the recommended results.